So I'm going to take this one step further and talk a little bit about the cell cycle inhibitors that are still really in clinical development. Let's see. And let's see, how did you guys get this to advance it? Green? Oh, I'm sorry, I'm pushing the wrong thing. So I'm good. I'm good now, thank you. So we're going to first talk about CDK4/6 inhibitors that are currently under investigation. I'm going to touch on Monarch I that was presented on Friday in the same session where Nick presented the ESR1 data on Paloma 3. And then we're going to talk about ongoing trials which are in all settings actually, metastatic adjuvant, post-neoadjuvant, and neoadjuvant treatment. So you guys have seen this slide. This is the third time now, just in case. So remember, you're supposed to remember where the nitrogen bonds are, so hint, hint. But you can see that these drugs really have very low IC50s for CDK4 and CDK6. They vary a little bit, but they are, the three agents really are quite potent, and the potency likely also impacts their activity. So the Monarch I trial was really designed to confirm the single-agent activity of abemaciclib in a phase 1 trial, and in a cohort of patients with ER-positive, HER2-negative breast cancer. In the phase 1 study, the single-agent response rate was 26%. So this trial was really designed to see, actually with a slightly higher bar of 25%, whether we could replicate those results. And so the primary objective of this study was overall response rate by investigator assessment. And this was previously treated patients. And this is really a very different study than the other trials that we've talked about, because this was in a much more heavily pretreated patient population. Patients from this study actually had already had prior endocrine therapy and some chemotherapy. They weren't felt to be any more suitable for endocrine therapy, and their next standard of care would have been chemotherapy. Besides the primary objective of overall response rate, secondary objectives were duration of response, progression-free survival, overall survival, clinical benefit rate, and safety. And it was a relatively small phase 2. It was a sample size of 128 patients to provide an 82% power, assuming a true response rate of 25%. So that was the bar, to exclude an overall response rate of less than 15% on the lower bound of the 95% confidence interval. And the patients who were eligible for Monarch I were hormone receptor positive, HER2 negative metastatic disease, progression on or after endocrine therapy. They had to have had prior treatment with at least 2 chemotherapy regimens, 1 to 2 chemotherapy regimens in the metastatic setting, and at least one of those regimens must have contained a taxane. So again, this is a very different trial from Paloma 1, 2, and 3, which were really first, second-line treatment with endocrine therapy. These patients did have a good performance status, ECOG of 0 or 1. They all had to have measurable disease, no history of CNS metastases, and they were screened for this trial, and there was no prior treatment with CDK4/6 inhibitors. And this study was actually designed before palbociclib was FDA approved. So 132 patients were enrolled in this trial. The median age was 58. And as you can see, 90% of patients had visceral metastases, 70% of patients had liver metastases, about 25% of patients had lung metastases, and you can see that about half of the patients had 3 or more sites of metastatic disease. So in terms of prior therapies of the patients treated on Monarch I, the median number of prior systemic regimens in any setting was 5. 100% of patients previously received taxanes in any setting, and the median number of prior regimens for metastatic disease was 3. For endocrine therapies, Approximately half of the patients had had 3 or more prior endocrine therapies, and about half of the patients had had prior fulvestrant. So when we think about how this population may have compared to Paloma 3, that was a fulvestrant-based study. These patients, more than half of them had already received fulvestrant. In terms of prior chemotherapy, you can see that more than half had at least one regimen. 68% had had taxanes in the metastatic setting, and about half of the patients had had capecitabine. And this is important because we need to consider these results in the context of response rates for patients who had already had taxane-based chemotherapy in the metastatic setting. And the drugs that are approved after treatment with paclitaxel or taxanes are eribulin, ixabepilone, and capecitabine. And really, their response rates in those metastatic trials are on the order of 10 to 20%, with progression-free survival of 3 to 4 months. And that's really the population of patients that were treated in Monarch I. And here you can see the response summary. So the confirmed objective response rate was 19.7%. There were no complete responses. They were really all partial responses. For patients who had had stable disease lasting at least 6 months, that was 22.7%, which translates into a clinical benefit rate of 42%. And you can see here on the waterfall plot. And this is the Monarch I treatment duration with a swimmer's plot. The median time to response was 3.7 months, which is really seen with the other cell cycle inhibitors as well. We typically don't see rapid shrinkage as we can sometimes with chemotherapy. It often takes longer to have that 30% reduction that's needed for a partial response. However, once patients have that response, they're typically durable. So you can see the median duration of response was 8.6 months. And 6-month duration of response rate was 70%, and 28% of patients who had had a response maintained that response for at least 1 year. You can see median progression-free survival for this heavily pretreated patient population was 6 months, and median overall survival is 17.7 months. And this is really still early because there's only been about 36% of deaths reported in this trial. So the most common adverse events in this study were diarrhea, fatigue, nausea, and decreased appetite. And really the toxicity profile of abemaciclib is very different than palbociclib. There's really more diarrhea. You can see 90% of patients had some grade, with 20% having grade 3 diarrhea. And you can see that the fatigue is more common as well, with about 13% of patients having grade 3 fatigue. However, the neutropenia is really less common. High-grade neutropenia, which is really grade 3 or 4, was seen in, let's see, I'm trying to find it's on the bottom there. The neutrophil count, grade 3 was about 20%, and grade 4 was 5%. Only one patient had a neutropenic fever, and that actually was in the 30-day period after study, and that patient had received chemotherapy. Also, what's very interesting is that almost all of the patients had a bump in their serum creatinine, and that's because abemaciclib competes with the receptors, MATE1 or MATE2 receptors in the proximal renal tubule that actually secrete creatinine. And creatinine is really just a marker for renal function. And so when they used a different test to check renal function, cystatin C, the glomerular filtration rate was not impacted. So although this is a lab abnormality that we see with this drug, it's not really a clinically significant abnormality. Now, we talked a little bit about the diarrhea, which this is really a plot that shows for each patient treated their diarrhea over the time of the study. And generally, the diarrhea happened very early within the first cycle of treatment. You can see the median time to onset was 7 days. So if you were going to get the diarrhea, you really experienced it in the first 1 to 2 weeks. The median duration of grade 2 was 7.5 days, and grade 3 was 4.5 days. And the diarrhea typically initially was grade 2 or 3. It was severe, but very responsive to a hold of study therapy, supportive measures with anti-diarrheal agents, and then dose reductions for a grade 3 event. So despite the diarrhea as a problem and more fatigue, really very few patients came off study due to an adverse event, only 7.6%, which is actually relatively low when you compare it to other studies. There were 3 deaths that were on study, but only 1 was possibly attributed to abemaciclib, and that was a patient who had pneumonitis. And then ultimately at autopsy, it turned out that she had lymphangitic spread of cancer. So, and the other 2 deaths were determined to be unrelated by the investigator. So in conclusion, abemaciclib, which is a CDK4 and 6 inhibitor, demonstrates single-agent activity in heavily pretreated patients with hormone receptor-positive, HER2-negative breast cancer. The overall response rate was almost 20%, with a median duration of response of 8.6 months, a clinical benefit rate of 42%, with a median progression-free survival of 6 months, and a median overall survival that's still early at almost 18 months. The safety and toxicity profile of twice-daily continuous administration was consistent with previous experience. Really few patients, less than 8%, discontinued treatment due to an adverse event. And what's important to note here is that with palbociclib, you have to take that week off. It's that 21 days on, 7 days off. And that continuous dosing really isn't possible. And with abemaciclib, it is possible. And there's thought that really that's an important benefit of abemaciclib, because you really want continuous inhibition of the target. You know, really we worry that with short-term inhibition of the target, you might have a rebound, and abemaciclib offers continuous dosing. And phase 3 trials are ongoing. The Monarch II study is a fulvestrant backbone with or without abemaciclib, and Monarch III is either anastrozole and letrozole with or without abemaciclib. So there are other trials ongoing with the 3 different agents. There are neoadjuvant trials. These studies are relatively small, as you can see. They're mostly phase 2 studies, the largest one being Monarch with abemaciclib, which will enroll 220 patients, and that study is still ongoing. The PALACE trial is a very large adjuvant study looking at palbociclib in combination with endocrine therapy for patients with hormone receptor positive HER2-negative disease. And this trial will enroll 4,600 women, and it's currently open. Hormone receptor positive, stage 2 or 3 disease, 1-to-1 randomization, and you can see palbociclib for 2 years with standard endocrine therapy versus placebo. Very important trial. Post-neoadjuvant is a group of women who have not had a complete response to preoperative chemotherapy. Women with residual disease typically have a high risk of developing a recurrence, and the Penelope trial is looking to add palbociclib to ongoing endocrine therapy. 1,100 women will be enrolled. Okay. Let's see. So just to summarize, there are 3 cell cycle inhibitors under clinical investigation. We've heard about these now a number of times: palbo, abema, and ribociclib. Abemaciclib is the one now that has single-agent activity in a heavily pretreated patient population. The differential potency of these agents against CDK4 and 6 may in part explain the differential activity and also the differential toxicity of these agents. And phase 3 studies in combination with endocrine therapy are ongoing.